It is a real privilege to be speaking in this meeting, and I share with you guys the frustrations, especially related to the GI tract, when you feel all these symptoms and treatments may not be as effective. So my objectives today will be to discuss the general manifestations of GI-related issues in patients with multiple system atrophy, and I'm gonna start talking from top to bottom. Then I just want you to be aware of something called the brain-gut interactions, which are very important in the development and in the cause of these symptoms that you are feeling. And then perhaps the most important point that I want to make today is to make you understand that early recognition of the problems with the GI tract and aggressive treatment of these can improve your quality of life. And then just out of curiosity, raise your hands, the ones who have any swallowing or constipation related issues. So quite a few patients. So the brain-gut interaction is very critical. I guess if I step out, you may not hear well, but so you have what we call the little brain, which is what makes me a neurogastroenterologist, and it's called the enteric nervous system. The enteric nervous system is a group of neurons that independently function to regulate interactions between the germs that you have in your gut, the hormones that go through, the food that get through, all of the immune antigens that you swallow and you eat and you breathe, and it's like a traffic controller. And believe it or not, it's so powerful that on its own can control the motility of the GI tract, meaning how you push food through, then also controls the juices, the hormones, and the secretions that your GI tract makes in order to help you digest, and also controls the blood pressure or the circulation to the gut, because in order to digest, you need to accommodate, and that's a very important part of the autonomic nervous system that we have discussed already. Then the good thing is that the enteric nervous system, although it's autonomous, it can be affected by bidirectional communication between the brain, which is kind of the main controller, then your spinal cord, which is like a stop in the signals. Then you get the vagus nerve, which is the main deputy that will control the signals and make sure that the GI tract functions adequately. And then the gut itself, that on its own, is very important to regulate things. For example, when you eat too quickly or too much, you get distension by the food, distending the stomach. Then the GI tract will send a signal to your brain, telling your brain, please stop eating. So this axis or this interaction is very important for you to understand why you're having all those symptoms. Then, specifically related to multiple system atrophy, there are several areas based on, as Dr. McFarland was saying, neuropathology, where it's being demonstrated that there is degeneration of neurons or part of the neurologic system in these specific areas. And one is the cerebellum. Cerebellum is very important to control swallowing. Basal ganglia, same thing. That's why it's frequently present in patients with this type of conditions. Then you have the vagal nerve that, as we mentioned, it basically controls the input to the intestinal tract in motility, secretion, and many other things like sensation. Then you have the spinal areas that are very important because the vagal control basically helps you to contract and get accommodated to digest food. Then the other part of the control needs a balance, so the spinal areas can control and counteract that, which is very important as well. Then you have the sacral lower part of the spine that controls defecation. That is a very important part of physiology, and that's one of the main issues that patients with constipation will have. And then, the anal sphincter is also very important to be controlled, and we have several abnormalities when you do biopsies and see the neurons that control these areas. So the good news is that based on the studies, there is no problem, or there is no alteration of the little brain neurons. Therefore, there is hope for eventually get some treatments that may improve the symptoms. Then from top to bottom, there is a lot of symptoms, and you guys, have experienced some of those, and you have known about those from these talks as well, including drooling, trouble swallowing, problems with the food pipe to push food through, a sluggish stomach, a sluggish colon, rotation or flipping of the colon on its own from constipation, and trouble to get the bowel movements out. And then all those factors will induce a significant problem with quality of life. Most of my patients that have neurologic conditions tell me that perhaps constipation and trouble swallowing is at least equal or perhaps worse in terms of quality of life. So this is a very important part. Then, for various reasons, including trouble with secretions, trouble with protection, trouble with reflexes, there is a risk for sudden death from suffocation on your own secretions. Then complications with medication intake, because if your stomach and your colon are not moving, your medications are not going to be moved either. And then obviously when you are not able to eat and enjoy food, then you may have some degree of malnutrition. So starting from the top, salivary problems with drooling are not uncommon, and the good news is that the issue is not that your mouth or your salivary glands make too much saliva. The problem is that it's difficult to get rid of the saliva or to swallow the saliva. Then the only way that the saliva that is pulling can come out is basically by just coming out of your mouth. The treatment for this is basically try to avoid medications that can make this worse, and several of the medications that you guys take can make this worse. Then behavioral modifications that are very simple, just getting set up times to swallow, because you may forget to do that, then you're going to accumulate more saliva, and then small or simple things like that can help significantly. Then there are other medications that dry up your salivary glands that don't have any significant central related issues, like ipratropium and glycopyrrolate. And then on severe cases, there is some case descriptions that Botox injection, this time to the salivary glands, dry up those glands and make you less likely to have the drooling. And then in very extreme cases, they have even done radiation therapy. Then swallowing disorders, in gastroenterology, we see swallowing in two main parts: the mouth and throat, and then the food pipe itself. And then patients with MSA have problems in both phases, perhaps more likely related to problems with the oral and pharyngeal phase, meaning what is in your mouth. And for various reasons, the mastication, chewing is difficult. The tongue moves not organized, and believe it or not, tongue movement is an important part of the propulsion of food from your mouth into your pharynx, into your throat. Then the sphincter, the valve that you have on top of the food pipe, needs to open up for food to get through. That may be altered, and then all those can give you significant issues with swallowing. Then the food pipe itself is very well described, that food can get there and stay there for longer than expected. Then the contractions of the food pipe may be weak. Then on time, when you have so much food getting retained, your food pipe is going to become dilated and baggy and not able to squeeze as strong. and you can even have very abnormal motility that push things back. This is a very significant problem, trouble with swallowing. In about 75% of patients is a common complaint, and is even more problematic with patients that have the Parkinsonian part or manifestation of this condition. And this is important because trouble swallowing can get things from your mouth and when you eat there, and that can go into your lungs, and that can do to aspiration pneumonia, which is one of the most feared complications from this type of issues. Then, as we were discussing, this is a progressive disease, and for whatever reason, the patients that have the Parkinsonian features tend to present these problems earlier, and the deterioration seems to be faster. And then studies also have shown that from all of those phases of swallowing, the most important part that is altered is from the mouth and the throat into the food pipe. So that's very important. I just wanted to point this from a study that basically show that the food pipe is dilated. The arrows are showing that the food pipe is featuring in like a darker like gray. So that's food that is staying in your food pipe. And they took 16 patients from which all of them have food retained in the esophagus and the food pipe. And from those, 7 were labeled as severe, meaning that the food was going all the way up almost to the neck, as you can see here. These are the clavicles, and this is your neck, so the food column was all the way up. What you can do to improve this, you have to avoid dried solid food, chew very well, watch things down with liquids, and you can try to modify consistencies. Liquid thickeners can be very helpful for this. Then when it becomes more severe, there are speech and swallow based therapies that have seen to help, the EMST, the expiratory emotional straining, the video-assisted swallowing therapy. Not all of the centers have this availability. Then there are some case reports that Botox to the food pipe, to the bottom of the food pipe, can let the food go into the stomach. And then dopaminergic drugs, driven stimulation, have been treated. And some patients may experience some improvement, some patients may not. Then, we have discussed already that you have to have an open mind, because what works for some patients may not work for others. Then there is always a chance to get tooth fittings. One thing that sometimes is a misunderstanding is that the fitting tubes will not prevent aspiration, and they should be only used as a means of nutritional support. The reason for that is because the mortality rates from PEG tubes are very significant, not because of the tube itself, it's because normally this tube is placed at the very end of the spectrum of the disease when all of the issues are more prevalent and more prominent. Then I'm just trying to go through all of the organs, so forgive me if I'm going too fast. But the other problem that is very obvious is that the stomach is not emptying, and then in this particular side, this is a normal patient that empties much of the stomach, and then there's a patient with Parkinson's, patients with MS that basically show that the emptying is dramatically more sluggish. And this is almost universally present in patients with MSA. What you can do, the main treatment for this is what we call gastroparesis diet, that in a nutshell is low fat, low fiber, because fiber and fat tend longer to get out of the stomach. So that's the main approach for this. Then dopaminergic receptor blockers, we have discussed that dopamine is a major player, and whatever you do to the dopamine can derange other axes. And the problem with some of these medications is that they may cross to the brain, and they can worsen tremor and movement disorders. One medication that has been used with some success is domperidone, that is relatively safe, and theoretically can kind of counteract a little bit the autonomic orthostatic hypotension that the disease itself and the medications that you may be taking can give you. So this is kind of a double benefit from this medication. Then we also use some antibiotics that, in addition to that, at low dose may promote motility. There are a couple of antibiotics like that, like azithromycin and erythromycin. Then there are other medications that can help with gastric emptying. One of these is one that has been recently approved, which is also hopeful because this medication, prucalopride, can also help with constipation. So with one medication, we can improve other gastrointestinal segments. And then there are other interventions that are a little bit more aggressive that have been try in small settings and small groups, and they may be beneficial, including Botox to the stomach, deep brain stimulation, cutting the muscle at the bottom part of the food pipe or the stomach, and this has been described mostly for patients with Parkinson's disease, but there are some case series that have treated this as well. Then constipation, perhaps is the most significant autonomic complaint. Is present even before the motor on the tremor is fully expressed, and that can be present for years, decades, even before that happens. And it's very important to be on top of this because it's kind of a marker of, the disease in the future. There are several complications that if you don't take this seriously can happen, like colonic bolus, which is twisting of the colon on its own from having too much stool, dilated your colon, making it baggy, so it's more likely to flip on its own. And then again, this is a significant limitation for the quality of life for patients and caregivers, and is equally frustrating to us as physicians. There's, again, several complications that can be very serious, including subduction, and sometimes you can get food impactions, fecal impactions, meaning stool kind of trap at the bottom that can be so bad that can limit the blood supply to the gut, and that can induce perforation and bleeding and colitis as well. Then, as we have discussed, because of the autonomic control, the brain-gut interaction, there are many causes for that. The colon is maybe sluggish. The rectum may have weak strength to push stool out. The abdominal muscles, because those are also impaired by this condition, can be weak, so it's more difficult to strain and push from the abdomen, which is a very important part. And the sphincter itself can be denervated. The anal sphincter can be very weak. So basically, what you do is to try basic things like diet changes. Then, if that doesn't work, you can have stool bulkers. That is the Metamucil. Then that may or may not work. Then you can have Miralax, which is going to be a laxative, making your stool a little bit less firm. Then you can try stimulant laxatives like bisacodyl that can give you a little bit of cramping. By the time that you are already fail all of these, then there's a good time to think about medications like prucalopride that will also help with gastroparesis. So it's good news. Then the Linzess medication has been recently in the market. That can help some patients as well. And then you can always reassess or change therapies. And the hope is that you will improve the transit of stool and the constipation. Then for patients that are not responsive, you can do biofeedback. That is basically a therapist that is going to make you aware when you're going to have a bowel movement and how to improve the contractions on the abdomen and the relaxation for the anal sphincter. At worst case, you can do enemas, which are very, if I done well, they will not hurt and they will not damage further your colon. Then you can use things like the sacral nerve stimulation that seem to relax the muscle and help a little bit. And the same thing that you can treat with fecal incontinence, because sometimes it's overflow from so much stool that basically stool will leak out. So very important to treat the constipation so we don't get all of these worse outcomes. Few slides about what happens. So this side here is a food pipe. It's called megaesophagus because the bottom wasn't opening well, and it became so big that it was almost occupying the entire chest. Then this is a colon that has flipped on its own, and is almost occupying also the entire abdomen as well. This is a surgical emergency. And then this is a megarectum, meaning the colon is so much full of stool that has this mottled pattern that definitely, by this stage, you will not be helped by laxatives or fiber. So the goal is to make sure that you treat this early so you don't get to these extreme conditions. Then I will save questions for the end.